Right, again, here I'm little biased towards certain things. FEMTO, why it can be a great tool for you and it can help you in your practice. I'll just skip out because in the interest of time, I don't want to talk about other things. I'm not here to promote any machine or anything. But how, as a friend, technology can help you to get you results in various kinds of cases. That's all. There is a learning curve. There is various things involved. I have less time, so I'm just saying that good predictability of the IOL positioning, corneal astigmatism, and early wow factor. Image guided assistance, it can tell you exactly where are you going and where are you headed. So nuclear fragmentation, rexes. So look at the planning of hard brown cataract. Now when you're doing that, as I said, a bad cornea with a bad endothelium here, if you are doing your case, you want a pre-chopped nucleus, you want a great rexis. I keep repeating that the core has to be broken, the rexis has to be good. Only then that your life will be a lot more easier. Once you got the hang of it, you can go ahead and it will break the nucleus. Your arcuates, majority of patients have some amount of astigmatism, 70% of them between 0.75 to 1.25. So a great arcuate, when I'm using a lot of multifocals, helps me, FEMTO helps me to get great effective positioning of my lens. It helps me to reduce my astigmatism. It helps me to plan my main incision and the side port incisions. Look at a pre-chopped nucleus which is there. You can easily just break it into smaller pieces and eat them up. So your phaco time, your fluidics time, everything goes down quite well and it helps you. There are various nomograms. Posterior synechia. So even if you have posterior synechia, you're not sure whether the pupil is going to dilate later. But again, as I said, on an extremely shallow anterior chamber, bad pupil, once you have access to the nucleus on a fairly decent level, you can be, now look at that, we have broken the synechia, you have got a rexis going. Yes, the posterior synechia can be broken. And good enough that the pupil wasn't IFIS kind of a pupil, it dilated, and I didn't have to use Suen's iris expander. I could go ahead and manage. So various cases where you're not sure what you're headed into. Now you have a white cataract, absolutely. What is most important here is, despite doing a femto laser, you may run off on the side. There could be adhesions. You have to be careful, never can you take things for granted. You have to peel off the rexis well, and you have a fairly fragmented nucleus here, which can help you. Well, despite your best femtos, some hard cataracts cannot break. A brown-white cataract will not be fragmented, whatever laser energy. So it's your manual skill which comes into play, but you have some access where you are almost sure that you have got into the nucleus well. That is a very important part of the surgery. We have 3 minutes? Okay. If I can put in a Malignant ring in a small pupil and then go ahead and do a femto. So once you put in a ring and you have gotten, I borrowed this from Boris with his permission that we're showing this, how we can use this, close the wound and go ahead and do your femto, which is fine. Here is again another hard cataract, Arcus, big cataract. This is an interesting case. I must show you. Did you see something interesting? This is an ICL. If you saw, there is an ICL here. This is the cataract. And you can adjust your femto in such a way that with the ICL there, you can still get a good rexis absolutely underneath, because it could be a very traumatic experience if you have the lens stuck at multiple places, you get bleeding and your iris goes down. So the precision, accuracy is something very, very vital to this. A posterior polar cataract, wherein you can have rings, you can have cylindrical parts. Very interesting. You will see that you have a pre-marked here on the right side. You can see it, the posterior polar going down below. Once you start your laser, you can make your rexis to your adequate size, just in case of the posterior capsule breaks, so that you can put an lens on in the bag, outside the bag, in the sulcus area. But look at the cylinders being made by the FEMTO machine. Becomes a lot more easier to dissect these cylinders and get them off at various points in time. Thank you. I wanted to flip through it quickly so that we can have a few questions. Any questions that you would like to? Yes, ma'am. I will like a regular one. You can calculate your regular IOL power. And if I've done an ICL myself or a LASIK also, I do a A scan and give it to them preoperatively. Yes, sir.
What are the conditions when we won't be able to do FEMTO second last year assistant Cargo?
When will I not be able to do a FEMTO? Whenever there is a corneal opacity. Yes. Anytime there is a corneal, if the pupil is very small, then you will have to use a pupil expander. These are the times when. Correct. So the whole capsule is not always thickened. Few areas where it will be thickened, but you have a good access to the capsule. So majority of it, almost 90% of it, you will have a good access. Wherever it is thickened, you'll have to be careful and or use your vanas to cut it. If it is really calcified anterior capsule with the cortex on that, then you'll have to do that. Yes.